of our discussion will be on how we can promote the implementation of the policy, and in such is how we can collaborate with you to advance strategies influencing meaningful change and better mental health outcome using our policy. And so I'll have some discussions to be able to demonstrate how we can have this collaboration and how using the policy we can bring the meaningful change and bring better mental health outcomes. And then the third area of my discussions will focus on how mental health policy impact in terms of overall health and socioeconomic development. These are three key areas you need as an advocate so that you can be able to champion the cause of mental health, which is, as I mentioned, policy advocacy is when you commit yourself to champion a certain cause. Next slide. So in this slide, I want to bring to you the awareness on what is policy, because if you are to champion the policy as a tool of changing mental health in this country, you need to understand what actually is a policy and the importance of a policy. So policy is usually defined as a statement of intent. So the stakeholders or the citizen commit that this is what we intend to do in terms of changing the mental health in the country. It's a policy document which guides and directs decision to achieve rational outcomes. So it's a key document which specifies specific directions, which if decisions are made in accordance to those directions, we can have a rational or a better outcome. Policy normally provides the general blueprint. It establishes a vision. A vision is what we dream to have in terms of mental health in this country. It describes the broad objectives and lay a foundation of specific actions which need to be undertaken by all citizens. Policy normally has a life cycle. I'll be demonstrating this in the coming slide, that it starts at a certain point and it may end at a certain point, depending on many circumstances. Normally, this document has to be endorsed by the executive power to give its legitimacy, to make it legitimate and put it in force. They are also very dynamic, informed by policy, by political influence, but also by evidence. So what I mean here is that policy keep on changing. We have seen there are different types of policy. We have educational policy, like we had the 844 educational policy. Now we have gone to CBC education policy. And all these are influenced by either the evidence which has been generated by the expert, but also by what is happening within the political sphere. You could have a certain government with a certain manifestos, and so they may have to change one policy or the other, depending on what they want to achieve. Policies can be anchored in registration. As you are aware, policy alone can't compel people to take some certain directive or action, but the law can compare or prohibit people behavior, so it can be able to bring some behavior change. So sometimes you may have to anchor some certain directive within the policy in the law so that you can enforce the implementation. The policy gives priorities consistent with the identified issue, and it also specifies what are the clear roles and responsibility of the different stakeholders. So in general, those are different characteristics or elements which characterize any form of policy. Just on your right, these are some of the key areas which has been addressed in our mental health policy. It has looked at issues of registration, human rights, the financing of mental health, organization of services. This is both promotive, preventive, treatment and rehabilitative services. It also gives directions around the areas of advocacy. It also gives directive on areas around human resource. It gives a directive on essential medicines and other things like special population. So basically, you pick on certain areas which you think are key elements which need to be addressed in terms of achieving your vision, and you give specific directive which all citizens must abide with. Next slide. So as I mentioned, the policy has a life cycle, and probably I will share with you what we mean by this life cycle. There's a time where you set what is the agenda, what are the issues or the problems you need to deal with. So as a country, we realized there were some certain issues around mental health services or in terms of the population mental well-being, and we said we needed to address these issues. Then once you identify the problem, you do what we call the formulation. And the formulation requires you to get a lot of evidence. You generate evidence on what is the best way to address these issues. Get into consultation and negotiation, so that this form of dialogue, so that you can have an agreement with all stakeholders. Then once you have the input from stakeholders, you can be able to say these are the key elements or the key issues we need to address. Then you put them together and you get the document endorsed by the executive power. Once that has been done, you need to move to the next stage of implementation, where you have to disseminate the document, get the buy-in so that the document can be adopted by the various stakeholders. Like in Kenya, we are talking of the counties, the people working in the area of mental health. And once you get the people supporting, what is your intention? As you said, the policy is an intent that you want to do a number of things to get to a certain vision. Then they are able to make the necessary decisions. They come up with plans and programs. Then from there, they move into implementing the programs and the plans by giving them the necessary resources required, by getting the people the resources which can be able to help in the implementation, human resource, financial, infrastructure, and everything which is required, engaging the community, including the people with lived experience. And then you implement the various programs you have as part of delivering on your policy. From there, you need to do what we call sustaining the policy and monitoring and evaluation. So this is a whole cycle which is continuous. And then once you finish the cycle, you can see whether you have addressed the issues you had in place, or you need to change the issues have changed, because as we mentioned, it's very dynamic. It could be one time our issue in the country is issues of substance use, issues of stigma around mental health, issues of lack of human resource and services. Probably within 10 years, those may not be the issues. The issues may be different. And then you may need now to come up with other intents and actions. So you need to keep on revising your policy depending on the prevailing problems and situations. So basically, that's why we are saying it has a life, and the life can keep on changing depending on the circumstances. So I wanted us to have that in mind. So basically, these two slides was just to give the general aspect about what is a policy, what is intended to do, and how it's formulated to achieve what people want to achieve in terms of mental health. Let's go to the next slide. So once you have the policy in place, as I have said, we need to implement it. And I would mention of 3 key documents you need to help in the implementation of a policy. You need to have the policy in place, you need to have a plan, and you need to have a program. Let me try to explain these 3 documents. We have already explained how we come up with a policy. I will not repeat that. Once you have a policy in place, you must set a plan. A policy tries to look for a vision and specific directive without going to the details for a longer period of time on the key issues which have been identified. But to address these key issues, you must now put a plan, which is normally between 3 to 5 years. And right now in the country, we have the Kenya Mental Health Action Plan, which runs between 2021 to 2025. After 2025, we'll review what we have been able to achieve, and we come up with another plan of 2026 to 2030. So how do you come up with a plan? The plan, you must determine the strategies and the time you need to implement the strategy. Then you set specific activities you need to undertake, and you set the target you want to achieve and the indicators you use to measure whether you are achieving those targets. From there, you must cost the plan. You must be able to say, this number of activities will cost this amount of money every year, and this is the way I'll get this money. And you must have that in place. Because we normally say without a plan, then the policy is just a document in a shelf. So once, if it's a county or at a national level, you adopt a policy, you must set a plan. And a plan is short term or intermediate term, 3 to 5 years, with activities, with the target you want to achieve, and how you measure those activities, whether you're achieving your targets. And you must cost. There must be a budget to implement those activities. And so then from there, you need to go to be more specific from having a plan to implementing a program. So within a plan, you may say you're going to implement a program on suicide prevention. That's one single activity or a single action you have taken up as a program. Another body may pick from the action plan and say they're going to implement a program on substance use prevention and treatment. That's another program. Another group of stakeholders may decide to take a program on stigma reduction or public awareness. So a program goes for a specific action or a specific activity and set a short period of time, maybe a year or two, on how they're going to implement that. So we are moving from the broad objective with broad set direction of what we want to address to a plan which picks on a number of activities over 5 years period of time and put the money required to do that. And then from there, different individual, organization, or counties picks on different programs and implement them. So that's the way we implement a policy. So it means there's a room for everyone to participate in this process. So when it comes to setting up programs, you need to understand the policy, which you say the dissemination and adoption of the policy, get the necessary support and funding, develops the, you can start by piloting the program you want to implement. Then from there, you're able to build the capacity to be able to implement that program, get the necessary resources, get partnership and collaboration, and also be able to interact with the community to achieve that. So on your left, there's a chart trying to demonstrate that at the national level, you will have the policy. And then from the national level, you will have the policy disseminated to the various stakeholders, both the non-governmental stakeholders, the various state departments and ministries and agencies, the private sector, and the caregivers, and everyone who is a stakeholder. And then from there, they are able to pick on various programs they can implement. So you'll see in that diagram, you talk about there's the policy at the national level, then you need to have at the county or as here they mentioned the district level, where they'll be able to set a similar kind of structures and systems to help implement the policy. And then they collaborate with various ministries, various stakeholders, build their capacities, get the necessary resources. This goes to the general population, where we normally say they are what we call universal intervention. These are programs targeting the entire population. Then you'll have other programs targeting the people who may be at certain risk, vulnerable population. And then you may go to certain programs targeting individual. And generally, by doing so, the policy will bring the necessary change we need in our community in terms of improving the population mental well-being and helping those with mental conditions to recover and live a better life where they're included in the society. Let's go to the next slide. So now we have explained what is the policy, how it's formulated, how you can implement a policy. I want us to see what are the changes a policy can bring, or what are some of the expected outcomes which will bring impact in our country. And this one I'm going to draw from our Kenya Mental Health Policy Action Plan 2021-2025. Our action plan has 17 targets, which we should be able to measure by the year 2025 to see how much we are able to achieve. And these will inform us as we go to the last phase of our policy. And I'm going to share with you what are some of the areas some of the things we want to achieve. The strategic objective number 1 in our policy is to strengthen effective leadership and governance for mental health. This is aimed at building stewardship in mental health and increasing resources, planning, and mainstreaming of mental health across board. So by 2025, the expected outcomes within this objective is to have county governments with costed mental health plans by 2025. We want to see by all the 47 counties in this country have a plan on what they want to do on mental health with some budgetary allocation to it. So we have an indicator which you can be able to measure that. The second item is every county and also at the national level to have multi-sectoral collaboration technical working groups. We should be able to bring all the partners together to make the implementation of this policy a success. So we should be able to measure that and see what are the progress we are making by the year 2025. The third target in the area of leadership and governance is to have a revised Mental Health Act to address the emerging issues and to be well aligned with the human rights approach. So I think we have already achieved that. We have a revised Mental Health Act, but that's not enough. We need to implement that Mental Health Act. So we should be able to see that we have a new registration and is impacting on the people. The fourth target is to have coordinators on mental health issues at the county level, sitting at the management level. So we want to see every other county recognizes mental health as a priority area, and it has an appointed coordinator who sits there to help in terms of planning for mental health and coordinating programs. The fifth indicator is to have the people with lived experience or the organization are supported and included in all activities in terms of implementation of programs and policy. So we want to see that there are many support groups, users, organizations, and their voice is being heard in terms of determining what needs to be done best for the people with lived experience. So that's an area where, so any one of stakeholder can pick on this as a program and run away with it. So basically, that's what we are saying. You can pick on the user organization, empowering them and to have them included in policies and in programs, and look for resources and implement specifically that as a program. Let's go to strategic objective number 2 in our plan. This is on implementing promotive and preventive programs with an aim to increase the mental health literacy, increase the mental awareness among our population, and risk reduction. There are 4 specific programs. That is public awareness and stigma reduction, school and workplace mental awareness, suicide prevention, alcohol and substance use prevention and treatment program. Under that, we are looking for key 3 targets. The first one is having counties setting up preventive and promotive program, regardless whichever one they pick on. They may pick on wellness, they may pick on suicide prevention, they may pick on alcohol, or they may pick on all of them, and they're putting resources on that. The second one we'll be able to look at across the counties is, are we able to reduce deaths coming from suicide mortality? The global prescribed for member state to reduce the suicide mortality is by 10%. The third one is also to reduce the alcohol use per capita, which we can measure in terms of looking at the alcohol use disorder-related morbidity and mortality by 10%. So again, if we are able to implement programs as prescribed by our policy and our plan, that's kind of the impact we are looking towards. Next slide. So our third objective in terms of the action plan for these 5 years is to increase access to quality mental health services at all levels. So broadly, this is supposed to bring some service reorganization where services are decentralized and they are integrated. We also look at where services are transformed. The current form of mental health services we have are of poor quality. There's a lot of violation of human rights. And so we want also to transform that and then increase how people access these services. So there are 5 targets within this area. The first one is usually to increase mental health services coverage at the county level. We want to see that counties have mental health services at the county level, at the primary health care level, and at the community level, so that we can shift services from Mathare Hospital to where services are more at the community level, nearer to the people, and people can access them. The second one is increasing training of primary healthcare provider and community health promoters. Because for us to take services to the primary healthcare level and the community, we must build the capacity of the community health promoters and the primary healthcare provider, medical officers, doctors, medical officers who are doctors, nurses, clinical officers. The third area is to also increase the number of specialists in mental health. We aim to have every county that 5% of their specialized staff are mental health professional, either a psychologist, a mental health nurse, a psychiatrist. We want counties to invest in training mental health professionals so that they can support those that are primary health care. So that's a key target. And the fifth one is training on mental health and psychosocial preparedness for the people at the county level, so that people know how to respond to the mental health issues during disasters and emergencies. So let me go to the final objective, is generally to strengthen mental health system so that it can address the issues of gaps in terms of mental health compared to the other healthcare system, what we call the mental health disparity, and bring equity. Basically, what we are looking at here is first the information system, that we are able to collect data at the health facility levels, at the community levels, and that data is reported to the national level and can be analyzed and be used to inform programs and interventions we are coming up with. The second area is being able to have people with mental health conditions enrolled to the Social Health Insurance Fund, and they are able to benefit from that in a mental health care package reimbursement program. The fourth one is we want to ensure that people get quality medication at an affordable price. So basically, look across the country, we have the first generational psychotropic medicine, which may cause a lot of side effects and may make people not comply with the treatment or adhere to the treatment. They also amplify the stigma because we are not able to demonstrate that we can give good care and people recover and get back to the society. So that's a key area in terms of ensuring there is access. Right now, the filling rate in terms of essential medicine is below 30% across the country. So we want to increase that filling rate to above 70%, and the filling rate to be of quality medication. Another thing I didn't mention around the services is the aspect of the paradigm shift in terms of offering services which are more human rights oriented and of high quality. We have a program we're implementing called Quality Rights, and their specific standard based on the United Nations Convention on the Rights of Persons with Disability. So this will bring an entire change or shift in the way we provide services, how we interact with people with mental illness by giving them more respect and dignity, and ensuring that they get into have a recovery and get back into the society. So there are a number of provisions which are within that kind of a program, which is also supported by the current law, the Mental Health Act. So we'll be developing a lot of regulations to help us implement the Mental Health Act and bring an entire change in the way mental health services are provided. So let's go to the last slide. So the last slide I'm sharing for you to be able to make further references. I've talked about what is the policy, how we come up with a policy. I've talked on how we implement a policy by coming up with plans and program. And then I've also talked on key areas which we have put as target to see that we can have outcomes and impact across the 4 objectives. And these references is where all this information is derived from. You can look at the World Mental Health Policy Plans and Program Guidance. This is a document provided for by the WHO. It provides step-by-step on how you can develop a policy, how you can implement a policy, how you can sustain a policy, how you can monitor and evaluate a policy. We have now the Kenya Mental Health Policy, as you can see, is in our website. You can look at it for more details, and the 5-year action plan, which we are currently implementing. So I think I'll stop there. I have given a snapshot of the kind of a policy we have, and we call upon you to, now that you're aware how the policy look like, what is the intended targets, and how you can go about implementing it. We want you to become a supporter of the policy to bring the mental health change we want in this country. That's what our advocacy stand for, that you commit to a public cause for the good of the nation. So thank you for giving me the audience.
Thank you so much, Daktari. To everyone, kindly appreciate Daktari. And I can see you doing that through the so many emojis that you're sending. Daktari has taken us through what mental health policy is, how we can come up with a mental health policy, how we can implement the policy, and of course, he's also taken us through mental health plans and of course the programs. The key area he has touched on majorly is on the mental health action plan, specifically the 17 target areas that some of us can tap in. I'm very sure not so many of us knew even about the documents that are there that guide the mental health aspect in our government. So right now, I take this opportunity to welcome your questions and discussions. You can post your questions on the chat, and Daktari and I will be able to answer them as much as we can. So I take this opportunity to welcome you to give your views. The chat is open. Okay, somebody is asking about the slides. She's given an email, but I believe KNH will be able to post this in their website and also in the YouTube channel because it's a recorded webinar. There's also a question on community health assistants. Is asking whether they can get the CPA points. Mr. Mwenda, I don't know whether you can answer that.
Yeah, for the community health assistance, we are not offering CPD for them because we don't have a council stroke board that is currently issuing them CPDs. Maybe we can follow up or they can do an email to us so that we can follow up if they have a council or body that is offering CPD points.
Thank you, Mr. Nelson. I hope he has been answered. Any other questions? Daktari, someone is asking, does MOH work with industry to control the alcohol dependency epidemic in Kenya?
Yeah, that's a very good question in terms of addressing issues of alcohol prevention and control. Specifically, we have the Alcoholic Drink Control Act, which is the overall law which guides in terms of how we do prevention and control of alcohol in this country. And that law should be used by the people in the alcohol industry, that they should know that this is what the law says, this is what they should do, this is what they should not do. Specifically, the law says this is the age in which that people below this age should not use alcohol. If you are putting up an alcoholic selling premises, there are specific laws saying this is what you can do and this is what you should not do. And basically, as we are saying, we should even be able to develop, review our laws and see, is it addressing issues of prevention and control? And if it's not addressing it, we should be able to amend the law. The law also, we can come up with specific regulations to further help implement the law. So all these things are in place. The ministry, I know, currently is developing alcohol prevention and treatment strategy. It would specify what we need to do as a country in terms of ensuring that we prevent alcohol as a major risk factor. I'd like to mention alcohol is one of the major health risk factors. It's alcohol use is attributed to 5.3 of annual deaths in a year. It's attributed to 5.1 of disability in terms of disease burden. It's associated by more than 200 diseases, and it leads to 11.3% of deaths for the people between the age of 20 to 35. So it's a major risk factor for mental health conditions, a major risk factor for non-communicable diseases and even communicable diseases. So it's a key focus guided by the WHO initiative, which we call the SAVOR initiative, where you should be able to address restriction of alcohol, access to alcohol. You should be able to address measures to reduce drunk driving. You need to increase measures to ensure there is screening, treatment, and rehabilitation. There should be measures to reduce or bring ban on sponsorship, marketing, and promotion using alcohol, because that's will cause more and more people having demand on alcohol. And then generally, there should be even an increase in taxation on alcohol products, so that all these are measures, well described by the WHO SAVOR initiative, which all countries should see that they are implementing those measures as they are agreed across the world as member state of WHO. And so as a country, that's why we need to strengthen our law, come up with strategies and regulation to ensure that we reduce as much as possible and control production, consumption of alcohol within our country, and also make sure that those who are affected by alcohol use get the necessary treatment. So yeah, basically, but then on the other side, as you have seen, we have these measures addressing the industry, but then we can't have partnership with the industry, which is contributing to a lot of burden and death with alcohol as a major risk factor. We should be able to be controlling them. so that we can be able to reduce the risk associated with alcohol. I hope I've been able to answer that question in our perspective.
I think you have, Daktari. And there's some more questions here. I know I can address one. Somebody is asking whether they're able to get a job. She says, or he says, is a registered nurse, mental health. To the person, I would encourage you to check the Public Service Commission website, because most of the government jobs are advertised through the Public Service Commission, and also the County Public Service Board. So you can check specific counties when they advertise their jobs, then you can apply. Daktari, I would want you to answer these particular ones. There's an interesting one asking about Mogoka. The person is saying, can you comment on the Mogoka or Mira issue trending right now in Mombasa? With that also, I'll combine this with that. The person in us is asking, does MOH, so I think that has been answered, but there's one on how can we strengthen mental health at community level? And then how can we motivate health professionals to take up mental health courses? Daktari, you are able to answer that?
Yeah, I think those are three questions. One on the aspect around Muguka. The other one I mentioned is how we can motivate healthcare workers to take training in the area of mental health. And I think the third one was on community health. How we can promote community-based mental health services. I hope I got it correct.
Yes, how can we strengthen mental health at community level?
Strengthen mental health. So I'll start with the one on Muguka. Yeah, what we refer as Muguka, we refer it as Mera or Cat. These are substances which have within them chemicals called cathepsin and cathine, and these are amphetamine-like substances. Amphetamine-like substances are psychoactive substances. What I mean by that they are a psychoactive substance is that they cause some changes in the way our brain functions. And some of these changes in the way our brain function eventually may lead to what we call addiction. Addiction is where you continuously have to use the substance. You increase the amount of, you have what we call tolerance, that you have to take more and more of that substance. And when you don't take that substance, you may experience some unwanted bodily effect, what we call the withdrawal effect, and have craving, that you need to take more and more of that substance to release the craving or to get the effect. And so Cat, Muguka are psychoactive substances which have addictive effect to the brain and many other health-related risk. They may also have socio-economic and other associated complications. In any country, when it comes to the psychoactive substances, there are laws which help in the prevention and control of these substances. And there are a number of laws. That's why we have the Narcotic and Psychotropic Substance Control Act. We have Alcoholic Drink Control Act. But, and then within this act, we classify the different substances within their different level of classification. There are those which are classified as in what we call Schedule 1. There are those we classified as Schedule 2, and those are classified as Schedule 3, especially following the Narcotic Drugs and Psychotropic Substance Act. Then we have other laws, and for specific for Cat or Muguka, there is a law which is embedded, which is within the Ministry of Agriculture. There is what is called the Crop Act. The Crop Act defines various crops which may be classified for as cash crop or subsistent crops and all that. And so this is why you are finding this debate, because there's a certain level we know some of the effect in terms of health complication and other complication, economic and socio-economic associated with Cat. But on the other side, we have a law which classify this substance as one of the crops within the country, and which is farmed as one of the crops farmed within our country. So these is discussions which need to bring all of us as stakeholders to see how do we educate the people, how do we look at our laws so that eventually we are able to address this issue. Whenever we encounter this kind of a situation, especially where a psychoactive substance is coming from a crop which is farmed within this country as a cash crop or whatever form of a crop, we may develop what are called alternative development. Alternative development is where you say, if there's a big community within this country farming this plant, and the law is saying is one of the crops, then we may need to give them an alternative as a form of their livelihood, as a cash crop, because what they are farming as a cash crop is causing major health and socioeconomic complication within our people. So it's good we're having these discussions. It needs to be informed by evidence. It must be informed by not any emotions, but people can be able to look as the health of the people as a priority before we look at any other issues related with that crop. So I think I'll stop there. And this normally applies even for other psychoactive substances derived from crops like tobacco, and there are specific programs, especially to develop alternative development for people who grow tobacco as a crop, so that we can be able to address the issues of the health adverse effect related to tobacco. Let me go to strengthening of mental health within the community. It's true within our strategy number 2, that's a key focus where we want to address the issues of wellness. And our key focus is on 3 areas: the family, the community, the school, and where people work. Because majority of the people spend most of their time within those areas. So if we are able to help them understand what is mental health, we address the attitude which are associated with the negative, with the stigma around mental health, and how people can take care of their mental health. So we are looking at the people who are not sick. Can you be able to address that the people are able to address their mental fitness? Then you can also do what we call risk reduction. There are certain risks within our family level, our community level, our schools, our workplaces. Can we reduce this risk? And then also, can we be able to screen and identify those with mental health issues? So basically also working with the community health promoters, having people we call the gatekeepers. This could be teachers, it could be the administrators, it could be the parent. Understanding mental health would be a major way of addressing this at the community level. Someone mentioned around the issues of encouraging mental health, healthcare workers to take training in the mental health. That's true. We really need to do much on this. And basically where I said our strategy number 4 is where we want to address the disparity, that there are areas where we have more people training in other areas like maternal health, reproductive health, and other areas. Can we do the same to attract more people? Addressing the issues of stigma, ensuring we change the way we provide services, probably will be a key point in encouraging and motivating people to go into mental health. So I think I've mentioned that, and I think I don't know whether there are other questions, and probably maybe Serene, you can also mention around what it takes to build up on terms of preventive and promotive intervention within our communities.
Thank you, Daktari. I think you've answered the questions very well. There is also one of our doctors who has contributed, and he has mentioned that the Alcohol and Drink Control Act, that is, I think it's 2010, is currently being reviewed to address the emerging trends. And of course, I think the issue of Mogoka or the cat will be handled in that particular act. Dr. You said that I should mention something on promotive prevention. it is a very key aspect in mental health, because we've seen that when we do a lot of work in prevention and promotion, we are trying to tackle mental health issues before they occur. So when we advocate for preventive measures or programs, we seek early intervention, and this can reduce the burden of mental illness. So some of the things that we can do is to introduce new types of mental health care approaches, things like mobile and internet-based interventions, the apps on mental health. We can encourage online technologies that are there. Even we can do therapies through the we call them the apps. So when we do that, when we introduce these new technologies, then we'll be able to provide mental health services with less stigma, and will increase accessibility. And of course, they are more flexible. That is, I can get mental health services at the comfort of my house without necessarily going to a mental health institution. Again, we need to advocate for programs that promote screening services, early screening services for depression, for anxiety, for substance misuse, and other hidden or overlooked mental health issues. So this screening will help in identifying individuals who are at potential risk for developing mental health conditions. This early intervention, it's very important because it will give us, as health professionals, opportunity to prevent conditions from worsening. So it is important that we engage in promotion and early preventive interventions for mental health. So having answered that, Daktari, somebody is mentioning.
I've picked
Sorry?
like few questions before you pick more. I've picked about 5 questions from the chat. Serene, can I go ahead?
Yes, you can go ahead, Daktari.
I've seen someone asking around how climate change, what are the influence of climate change to mental health. And the last time I had a webinar with you, for those who may have joined, we talked about what we call the social determinants. The social determinants are things we see not as the normal, not as the risk factors which are identified to affect directly in terms of the causation of a disease, but they have an influence in terms of how you may develop the disease, how you may recover from the disease. We say these are things in where you were born, where you live, where you grow, and where you work. They are called social determinants. And climate change is one of these things. And we know climate change can come with a lot of changes, disasters, which may cause a lot of trauma to the individual. They may come up with issues like drought and famine, which may affect people in terms of their nutrition. They may cause effect in terms of the socioeconomic. So these things do have effect in terms of the causation of how they modify the risk factors, how they affect in terms of how you access services and how you recover from any mental health condition. So I would mention climate change is a major social determinant. Someone have asked around methadone, how you get into the methadone program. Methadone is a medicine we use for the treatment of the opioid use disorder. Is a controlled substance. That means that it's not available to everyone. It's a highly controlled substance because it's an opioid substance which has a long half-life. So it's used to address the opioid use, especially where people are having heroin use, which is a short-life opioid. And by ensuring people get care within the hospital, they get what is called the full package of care. They address all aspects holistically about their life. We are able to get them from any other issues or complications associated with heroin use, like a crime, issues like sharing needles, issues like they can contract HIV and hepatitis B. And so methadone has been shown to really bring a major change in people's life. We have about 13 clinics across the country, and where people get the whole package of care, from addressing the psychosocial issues, getting them from addiction from heroin, to addressing issues around any other communicable and uncommunicable diseases they may be experiencing, and also even supporting them with a number of supporting NGOs to get to have some livelihood. So there are those centers, you can visit them and you can be told on how to enroll. There are also NGOs working within the community, which you may get in touch with and help you get enrolled within our methadone treatment program. For how long you'll be on methadone, is encouraged to be on methadone for a long period of time, and then with the doctor assessment, you'll be able whether you can get you out of the methadone and continue with the various form of medical and psychosocial support to reduce any form of relapse. Then there's a question, do we have challenges implementing the policy? Yes, true, we have very many challenges. And as I say, first is even having the policy disseminated as widely as possible and people being able to adopt or committing themselves to implementing these policies. The second one is the area of finances. All those activities we have and put targets, we can only achieve them by having financial resources and also human resource to help in the implementation. Stigma is still also a major problem because if an issue is stigmatized both at social level and at systemic level, it affects in how we are able to allocate resources or prioritize it. So these are challenges. And next year and getting to 2025, we'll be evaluating our current plan and be able to re-strategize for 2026, 2030. There's a question on issues of confidentiality and privacy. The Mental Health Act stipulates very clearly how we should be able to address issues of confidentiality and privacy. And current law has a whole section which addresses the issues of human rights. And so this is very different from the Mental Health Act of 1989. E-cigarette is it's not recommended. People who want to be treated for nicotine dependency and to stop using tobacco product, there are specific programs on how they should get care. Tobacco is a major psychoactive substance with a high prevalence within the country. People should be able to go for services. There are psychosocial intervention as well as pharmacological intervention, which should help you to stop taking a tobacco product and recover from nicotine dependence or nicotine addiction. So basically, e-cigarette is as harmful. I would also mention what has been marketed of late, other tobacco product, which are sold as some are sold as things you put in the mouth. They are also as harmful. Tobacco contains a lot of carcinogenic product, and also it contains nicotine, which cause addiction. So maybe Serene, you have picked others as I was answering those ones.
Yes, Dr. I would want to address somebody who is saying, I'm mentally stressed from the effects of my son, who is an adult and was in alcohol despite spending 6 months in the rehabilitation center. He came out now worse than before. Will it be wrong to send him in prison for children neglect? To the person asking the question, prison is for those who have committed crime. And I was just wondering, if you send your son to prison, would you be helping him in terms of treatment? And therefore, I would want to encourage you to seek help, because you need to realize that alcoholism is a disease. And once you are addicted to alcohol, at times you have no control because it has already affected your brain. And so an addict does not have, sometimes they don't have control of their actions. They have that inability to control the use of the illegal drug or the legal drug. So I would encourage you to seek help for your son. Remember, addiction treatment is a process. Once in a while, the person will relapse even after treatment. And therefore, we shouldn't lose hope in providing help to our loved ones. We need to encourage them to seek for help more often. If one rehab center didn't work, we can still look for other options of treatment for the person. But sending your son to prison will not provide that treatment that they really need. So I would encourage you to still look for help for your son instead of thinking of taking your son to prison. I hope I've answered that. Dr. Would you want to add something?
No, I think you have addressed it very well. That alcohol use disorder is a chronic illness, is a chronic disease, and as I mentioned, with many chronic diseases, hypertension, diabetes, you may have people with these conditions having recurrence of the condition or relapse, and the treatment should be looked at in terms of long term. I would also like to mention this is an area where we, as you saw in our policy, we realized there is a deficit in terms of access to treatment and rehabilitation services for alcohol and other substance use disorder. And so one of the key programs is on how we can increase our prevention, but also increase access to treatment. The ministry came up with a protocol on how people should be treated, which clearly stipulate the standard we should have in terms of treatment, the necessary steps, step-by-step guideline on how you should address each of the various alcohol and substance use disorder. Further to that, after the task force saw the need of setting regulations to address the licensing, registration of treatment and rehabilitation facilities, and ensuring they meet the necessary standards. So as a country, we should be working more to increase the coverage in terms of people can get treatment, the quality of the treatment, and also getting more and more people who are well capacitated to provide this treatment. So it's an area of focus of this strategy. And as Kenyans, as we get to 2025, if we think we have not done enough, we should come up with more strategy focusing on these issues of alcohol prevention and access to treatment in terms of various alcohol and substance use disorder. So I understand the frustration where things may not be working as we expect, but as you have been encouraged, it's a chronic disease, and we are also working in terms of improving the services provided for people with this condition so that we can get better treatment, recovery, and we prevent them from relapsing. But to emphasize, prevention is the best way to address issues of substance use. Prevention focusing especially in the adolescent and the young people. As you saw from my statistics, the people between the age of 20 to 35 are the most affected, where 11.5 of deaths within this age group are to do with alcohol use-related disorders. Back to you.
Thank you, Dr. Few more questions, but I just want also to add something on what you've said on prevention. Even as we talk about prevention, we need to address issues of adverse childhood experiences, the traumatic events that happen to us in childhood. Most of them are linked to lasting issues in mental health, or they have harmful consequences in future for people. So we need to address adverse childhood experiences. And by doing that, we need to talk about how we address our parenting skills, how even the environment that we live in, how adequate is it that to minimize mental health issues. So we need to address those kind of issues because they have a long-lasting effect on our mental health. A question on do we have rehabilitation services at MNTRH? Yes, we do have a rehabilitation center at Mathare Teaching and Referral, National Teaching and Referral Hospital. And if you need to bring your person to our rehabilitation center, you can visit us, and then we can advise on how you can go about it. Daktari, a question on can we give scholarships so that we can encourage more ventures in mental health, especially for clinicians who offer daily outpatient services to patients? And then can you consider offering free consultation for a patient that is referred?
Yeah, very good question in terms of how can we be able to promote and support people who may want to undertake training in the as mental health professional, especially for those who are working at the primary health care level, the clinician. It's true, this is one of the way to go, especially if you are to reorganize services, having some services more integrated and decentralized and integrated. Currently, we have a few programs, especially there is one of our NGO, community organization supporting the training for nurses. And I know they offer scholarship for nurses from various counties. The policy also, as you saw, one of the target is where we are trying to encourage counties to have 5% of the healthcare workers as mental health professionals. So it's not a big thing to ask for county government. We are saying if you have around 100 staff in a hospital, 5 of them should be trained as a mental health professional, either as a mental health nurse, a clinical officer done psychiatry, or a psychiatrist. And I think that's a small number, 5%. I've given an example of if you have 100 staff, 5 should be mental health professionals. If you have 50, then 3. Because we are seeing some counties where they have no single mental health professional. And so for even other healthcare workers to start providing mental health services, they need someone who is mentoring them, who is giving them supervision, or who they can refer to. So that is one of our targets for 2025. And the only way to achieve this is to have a county ring-fence some money specifically for those who may be to give priority to those who may want to train in mental health so that they can achieve that 5%, which is within the policy. So like I've brought this webinar today, it's aimed at giving you this information so that you can become a better advocate, that as a county or as a parastatal, as a KNH or as MTRH, do we have 5% of our healthcare workers when they are recruiting, when they are giving scholarship for training? So even at the national level, I know we have a proposal to the government to try and see whether we can get more funding invest for mental health training. So it's true that can be done. There was a question I saw in the Q&A platform around the use of naltrexone. When we are dealing with the alcohol use disorder, there are various forms of treatment, ranging from the most important thing is first to identify what is the problem and related problems, because most of the alcohol use disorder come up with other problems. You may find someone who may be going through trauma or has had a childhood adverse event, or may have depression, may also have other non-communicable and communicable condition. So basically, holistically, the patient should be looked at from that perspective. A specific treatment plan is put, guided by our national treatment protocol. So naltrexone is just one of the product of the many products you can use as you are managing alcohol use disorder. But you can't put your focus on one product and you aim to get better results. Multiple interventions put together give better outcomes. So let's not focus on one intervention and thinking it would have a magic psychosocial intervention, family therapy, and all that. So I will need to encourage where we are well guided by a national guideline or protocol and we provide better care. There was a question on someone has observed young people sniffing petrol, and I don't know what other product. I would say yes, it's true. These are psychoactive substances. These are petroleum product. are grouped together in what we call inherent. They are within a big group of what we call depressant types of psychoactive substances. They are addictive and can have effect in terms of brain health. I think those are the few questions.
Somebody was asking about relapse, how we can handle relapse. Can you hear me? Sorry.
Yeah, I can hear you about relapse.
Yes, how we can handle relapse.
Let me first talk about this terminology. The word relapse, recurrence, and remission, and probably even what people may consider recovery. These are terminology. What we talk about relapse is where you're in the early stages of your recovery, but then the problem get worsened. So probably when you are discharged from the hospital, it doesn't mean you have recovered from the certain conditions, whether it's a mental illness or a alcohol addiction or any other psychoactive addiction. It means there should be
Dr. You're breaking up. Dr. You're breaking up. I don't know whether it's on my side alone.
The necessary. Hear me now?
Yes, now you're clear.
So what I'm saying, I wanted to clearly talk about this terminology where we talk about someone has relapsed, someone has had a problem recurring, someone is on remission, or someone is on recovery. So when you talk of relapse, you mean someone who has left the hospital or has left an outpatient management plan. The condition they have been suffering from when they have been trying to get better, it exacerbates or it gets. That's what we call relapse. And basically, whenever you have a relapse, it's normally said is part of the cycle of recovery. So we always need to go back and look, why are we having the problem which was getting better worsening? So there are many factors around that. And with good engagement with the patient, with their family, and all the things around, even you yourself as a doctor reviewing on how you're handling the treatment, you can be able to see what are the factors contributing to relapse and address them. So we normally say relapse is part of the cycle. What is remission? Remission is when someone has been on treatment, may go for a prolonged period of time without having the disease recurring or any of the symptoms. And we normally address that there could be a risk that this problem may recur again, even if you are no longer in the symptoms. And that's why we encourage people, even when they're not feeling well, if they have had some of these mental conditions, to have regular contact with their mental health professionals or mental health practitioners to be able to see how they can maintain the good progress. So you don't have to go to a mental health practitioner when you're unwell. You should maintain that relationship. What may vary now is the scheduling of appointment on how, or even the mode of how you do the appointment. Then, that's why I've talked, there's remission, there is recurrence, and then there's also what we normally encourage people that probably you may be living with this condition and there's a chance of it recurring. Some people may have one episode and it may never recur again. And so they may be said almost to be like on recovery remission and all that. So I don't know whether I've been able to address that about the use of that term.
You have, Dr. There's one particular one I would want you to address. Someone is asking, could MOH address the issue of human rights for the mentally ill, like access to mental health treatment for these people? We have normalized as madmen in the townships with none to help.
Yeah, that's a very good question on the issue of the human rights. I would like to mention Kenya is a signatory to what we call the United Nations Convention on the Rights of Persons with Disability.
Dr.
people
you are breaking
with
up again. Sorry.
mental conditions or people.
Dr. You are
Question,
breaking up again. You're breaking up
can
again.
you hear me now?
Yes,
Can you hear
now
me
we can
now?
hear. Yes,
I'm
we can.
saying the issue of human rights is a pertinent issue. As a country, we are the signatory to the United Nations Convention on the Rights of Persons with Disability. And 2019, we initiated a program, what we call Quality Care and Human Rights Mental Health Initiative. Its aim is to do 4 things: create awareness on what are the human rights of persons with mental conditions and psychosocial disability. The second one is to ensure that services adhere to the human rights standards. The third one is to ensure our law has been reformed and stipulate specific provision on how to address issues of human rights, and the current Mental Health Act does that. And so for now is for us to be able to implement those provisions in the law, because the law as written need to be implemented for people to get the impact. And the third part is trying to train healthcare workers and the general public on these issues of human rights. So those are the 4 key pillars around the Quality Right Mental Health Initiative, which is aimed at addressing the issues of human rights. Because a human right has been a major driver of stigma and discrimination for persons with mental condition and psychosocial disability. Back to you, Serine.
Thank you, Dr. Just to wrap it up, some few last questions. Someone is asking, are there rehabilitation center for sex and gambling addiction, if you know of any? And then in line with the UHC special provision for mental health, geographic coverage and financial access. I don't know whether they're asking a question or not, but kindly address the issue of rehabilitation center for sex addiction and gambling. And also a question on LGBTQ. Earlier days, it was considered a mental illness, but with time has been considered a lifestyle. Has it changed?
Yeah, so those are 3 questions. I will start with the one on the aspect of gambling and sex addiction. Yeah, so basically the current classification of mental conditions put some of those conditions as some of the emerging issues and of special considerations. And even if they're not very specified diagnoses in the classification of diseases, they are of special interest which need to be put into consideration. And when we put treatment and rehabilitation facility, we don't specify them that is for alcohol or they are for opioid, any form of addictive diseases. And that's why when we talk about alcohol and substance use and related addictive diseases, we make sure we have that word related so that any form of addiction can be addressed within those facilities. And secondary is, and they can be addressed at various levels. There are those conditions who may be addressed at the community level, at an outpatient level, or as an inpatient. Then there is the aspect around the UHC. UHC has the 3 elements: universal health coverage. As you heard, the word universal means like everyone is covered universally. So we need to ensure that people with mental health conditions are included. That's what I mean universally. Then there's the aspect around making people that they have mechanism of financing so that they don't go through the financial burden. What currently the Social Health Insurance Fund is working on, they're working on reimbursement tariffs. I think mental health has been considered. There is a package. I know this has not been launched to the public. It has been considered both outpatient, inpatient, and treatment and rehabilitation. So I think these will be announced to the public very soon. And that's why one of our target is to ensure as many as possible persons with mental conditions have an NHIF card or an SHA card, what we are calling Social Health Authority card. So they are registered. Those who can be able to afford because they are having severe disease causing them disability, would encourage them to be registered as person with a disability, and then they can get to be waived from those monthly premiums. And then they can be registered as a person with a disability and get the same services. Because that's the only best way to achieve these services. So then the other aspect about UHC is having health systems that if you are covered by SHIF, what is Social Health Insurance Fund, then are there services, and services are they of good quality? Because you could be covered, but then you can't access any services. So you need to ensure the coverage of services is as broad as possible. And that's why we want to encourage that mental illnesses are not only treated by mental health professionals, especially at the health centers and the sub-county hospital. Medical officers, general nurses, and clinical officers can be guided with the tools. This is a guideline and can be able to treat, and then from there they refer. And this is the same setup we have with all other medical conditions. Patients with diabetes are treated in the health center. Patients with the hypertension, patients with requiring HIV care are treated. And the same thing should be able to apply for mental illnesses. The third aspect is on the LGBTQ. Yeah, we talk about the issues of diversity in terms of sexual orientation. It's true. Many years back in DSM-2, these may have been considered, but subsequent review is not classified. But we do have what are called gender-related conditions, and especially is what we call gender dysphoria. And this is where the aspect of your gender may be causing significant distress in you that you may require some psychological intervention. But to mention, LGBTQ community in our policy is considered as a special population because they may have special needs. They go through a lot of stigma and discrimination and a lot of violations, and therefore they may be more vulnerable to mental health issues, and they may require targeted intervention for that population because of the risk, because of their vulnerability in addressing their mental health. And so this is an issue where we are working with healthcare workers and also these organizations to see that the business of a doctor or any healthcare workers is not to discriminate anyone, is to provide them with the healthcare services when they are in need. And I think that's the way what guides in terms of medical ethics. You provide services to whoever comes to you without judging them, without any form of discrimination.
Thank you, Dr. Harry. Thank you, Dr. Harry. Our time is up. I believe we've been able to answer most of the questions that were posted in the chat. For those whom we've not been able to capture their questions, you can still seek for our services at Mathare National Teaching and Referral Hospital. For now, I would want to really thank Dr. Harry for that good and informative webinar that you've given us. And also to thank KNH UON for the platform. And of course, Mathare National Teaching and Referral Hospital management for bringing in this collaboration to inform the public about mental health. We've run this series of webinars for this whole month. We'll be able to inform you on our future webinars starting next month. We'll encourage you to continue joining our webinars and learning more on mental health. If you need more information, if you need any mental health services, kindly seek help at Mathare National Teaching and Referral Hospital or any other facility that offer the services near you. Thank you so much for participating and for joining us. I take it back to Mr. Mwenda to wrap it up. Mr. Mwenda, are you there?
Yes, I am. We thank everyone for attending this session. We still continue with our KNH UON webinar series. Tomorrow we will be having another one that will be running from midday to 1, not as usual 2 to 3:30. So for tomorrow, we run from from 12 to 1 p.m. We thank everyone for attending. Please continue attending our webinars. Thank you very much for the collaboration with MNTRH.
Thank you and bye.
Thank you. Thank you and bye.